Welcome everyone for this afternoon teaching on or seminar rather by LKC Medicine Group, and also honored to have Professor Sharon Fekrat from US Duke University. She is Professor of Ophthalmology there and also the Vice Dean for Faculty Affairs. And as a clinical role, she is the clinical surgeon for vitreoretinal surgery, training many peoples, the surgeons there in US, and also handling the research work there. And she has been a long-standing collaborator and a friend for. Yes, not more. Okay. So as she's going to be talking to us about the iMIND, which she'll be sharing a little bit more detail. And this is just a snapshot of what their group is working, but I leave it to her. But for me, I've been amazed that we are meeting her for the first time. I'm meeting her for the first time in person, but this is all the work which has happened. We have published 9 papers without meeting her. So Sunny just wanted to highlight on how you can work remotely and still get to very healthy publications related to the imaging in the eye and of course what's happened in the brain. So with that, I'd like to invite Professor Fekrat to give her talk. Thank you very much.
Thank you. Thank you so much for that warm welcome. And I really appreciate the opportunity to be here and meet everyone. And I look forward to the many future collaborations that we're going to have. So we're going to just go ahead and start with this slide. And I know that we have an audience with a very different background. So we'll start very simply. So just take a minute. This is very instructive, and just look at these eyes. What do you see? You know, at first glance, we just see the obvious, the eyelashes and the eyelids, the pupil, the iris, but there is so much more to the eyes. And in fact, when we look through the pupil, and when I was first starting with eyes, I looked at every person as a pupil that I could barely see the retina. But when we step inside, there's so much more, right? So back there's the retina wallpaper, the optic nerve, the choroid. There is so much more behind that pupil. Oh, thank you. Let's try it. Great. So in the back, as I mentioned, there's a neurosensory retina wallpaper. There are retinal blood vessels, the optic nerve that comes from the brain. And believe it or not, we spend our entire career studying a very small part of the human body, the fovea of the macula of the retina. And we can get very detailed and look at the microvasculature. And then, of course, right underneath is the choroid of the macula. So we currently use retinal and choroidal images to diagnose retinal conditions, but let's think outside the box for a minute, outside of the eye. Because very often we just look at what's in front of us, and we really need to think big and think about what else could we use eye images for. So our eyes are direct extensions of our brain and windows to our brain health. In fact, the eye is the only human tissue that allows the non-invasive direct visualization of the microvascular circulation in the body and the central nervous system itself. And many studies have shown that changes in the eye mirror changes in the brain. In fact, the eye and brain do have a lot in common. Eye fluid and spinal fluid have many similarities, and I think in the future, many of the eye conditions that we study are going to cross over many of the neurodegenerative changes that diseases that are also being studied, such as complement inhibition in macular degeneration and Alzheimer's disease. So, oh, back up. Thank you. So amyloid and tau proteins have been found both in the spinal fluid and the vitreous humor from work being done at Boston University. And then our group has shown that in the aqueous humor too. we have detected levels of phosphorylated tau 181, and that's positively correlated with plasma p-tau 181, and negatively correlated with the Montreal Cognitive Assessment blind scores in patients undergoing cataract surgery. In fact, the eye and the brain have even more in common than sharing the fluids. Hippocampal shrinkage and ventricular expansion do correlate with reduced retinal microvasculature in Alzheimer's and mild cognitive impairment that we refer to as MCI. And this is very fascinating work with volumetric MRI scans of the brain. So can we use eye pictures to diagnose neurodegenerative diseases, including Alzheimer's, Parkinson's, multiple sclerosis, ALS, frontotemporal dementia, Lewy body dementia, the list goes on. And maybe, but you ask yourself, why? Why would you want to? And just to show, I've seen some of your large spaces here. We have a very small little room where we have our imaging equipment there. It's about 5 feet by 8 feet. So a lot of work can come out of very small spaces. And so there are many reasons that you would want to know if you were headed to get Alzheimer's disease. So an early diagnosis, this is from a study in Alzheimer's dementia a couple of years ago that surveyed patients and said, why would you want to know? Because you say, why bother to do retinal images in people? No one wants to know they're going to have dementia later in life. Well, it said it would allow me and my family to plan for the future. It would give me more time to assemble my care team. We can rule out irreversible causes. You can participate in clinical trials. You can start new medications. So there's lots of reasons that you may want to know early. Then they ask, well, what stage would you want to know if you had Alzheimer's? Well, the majority, 54%, said they'd like to know at the mild cognitive impairment stage. And so I'm surprised by that. I want to do 23andMe, but I'm waiting because I think I don't really want to know what my genetics are. So right now, how do you find out if your memory issues are related to Alzheimer's? Is it just normal aging? Is it another type of dementia? Well, you have to go through a lot of invasive, expensive testing. And in the United States, PET scans, which show amyloid accumulation in the brain, were not reimbursed by insurance companies. So if a patient wanted it, they would have to pay several thousand US dollars to get a PET scan. Now, more recently, with FDA approval of some early treatments for Alzheimer's, now our Medicare, for example, will pay for a PET scan. But that is very expensive, it's invasive, and we know that Alzheimer's pathology begins 20 years before symptoms start. So if you didn't want to get a PET scan, what else could you do if you wanted to know if you had Alzheimer's? Well, you can get a spinal tap, but I don't think I would really want a needle too close to my spinal column if I had a choice. You could get a blood test, and maybe in the future that's what it will be. You just go and get a blood test and find out your amyloid ratio and other biomarkers. But that's very non-specific right now, and has a lot of other factors that can make those values change. Or you can get neuroimaging, but that's not necessarily very specific, where you see shrinkage of the brain and enlargement of the ventricles. So often in the US, at least, neurologists rely on clinical symptoms alone and approved criteria. But without all these additional tests, it was fascinating to learn that 1 out of 3 times the diagnosis specifically of Alzheimer's is wrong. And I've been thinking, over 400 clinical trials looking at new treatments for Alzheimer's have failed. And you ask yourself why, maybe amyloid isn't the best biomarker. Maybe that's not an indication, because there are many individuals that have amyloid buildup and are cognitively normal. So it's probably that some participants in clinical trials, they may not even have Alzheimer's. And so they're enrolling patients with memory issues who have a clinical diagnosis of Alzheimer's, and maybe that's why a lot of treatments that have been studied have not been successful. So we do need an easier way to diagnose Alzheimer's disease before symptoms start so that Alzheimer's patients are diagnosed correctly and they are put in Alzheimer's clinical trials earlier when maybe the disease is easier to treat. And then, we may be able to have some more successful clinical trials when appropriately diagnosed patients are put in appropriate trials. So the answer to making an early diagnosis of Alzheimer's disease may be right in front of our eyes, and that is with multimodal, choroidal, and retinal imaging. In fact, there are so many images. There has been an ophthalmic imaging boom. I look at all of these wonderful things. So the optical cross-section, the OCT of the macula up there on the left, you can see every layer of the retina just beautifully, almost like a histologic cross-section. You can see in the bottom left, OCT angiography. And for those of you that don't know, when you hear the word angiography, you think it's invasive, but it's actually not. The OCTA takes about 70,000 scans per second. And in doing that, it can map red blood cell movement. And that's how it maps out those tiny little blood vessels that surround the fovea in the macula of the retina. And those blood vessels are 5 microns in diameter. That is not even the width of a human hair. And so we can get so much information: vessel density, ganglion cell layer thickness, retinal nerve fiber layer thickness. Now there's recent software that can actually measure every single layer of the retina and the thickness up there in the OCT of the macula on those scans. And then we have the choroidal vascularity index image, peripapillary angiography, bottom right. So these are non-invasive, they're inexpensive. You can do them undilated. There's no radiation. They're widely available. Almost every office, at least in the US, has this imaging equipment, and very high resolution. And so then you have to ask yourself, well, where do we look? Right? It's very similar to having a child. They could be a tennis champion, but they never took tennis lessons. So where do we look? And we're really trying to figure that out. So we are looking in the macula, in the top left there. We're looking at the superficial capillary plexus, because in the retina, there's all these different vascular layers. And then we're looking at these metrics: the perfusion density on the bottom left, which I always have to think about the definition. It's a total area of perfused vasculature per unit area in the region of measurement, which we'll talk about in a minute. And then vessel density, which is the total length of perfused vasculature per unit area in a region of measurement. So we know what we've chosen to look at so far: the superficial capillary plexus in the macula. But then what are our regions of interest? And that's something you've thought a lot about with COIN as well, and measuring CVI. But we have chosen something that has been proven already, or is an accepted region of interest in our profession, and that is the ETDRS measurement areas. ETDRS stands for the Early Treatment Diabetic Retinopathy Study. It's a 3-millimeter circle and a 6-millimeter circle, and it has rings and quadrants and circles with and without the center. And so we have chosen to look at these regions of interest. We're also looking, using the Zeiss Cirrus HD 5000 angioplex, we're also looking at the peripapillary superficial capillary plexus, and we've chosen the 2 metrics at the bottom: capillary perfusion density, and the definition is there, and capillary flux index. And then, of course, we've recently started collaborating and looking at the choroidal vascularity index, because what we were doing before was the subfoveal choroidal thickness, and that is subject to variation related to many systemic parameters. And so we've been very excited about this metric and really appreciate the collaboration. And so we've been using the COIN platform, which many of you are familiar with, and we also heard more about it this morning. And we've published quite a few papers in our collaboration, which we've been very grateful for and learned so much. So we've realized that image quality matters a lot, right? So garbage in gives you garbage out. And so what we've typically done is we've done the manual image quality review. You have to train people what a good image is and a bad image is. You have to have two people manually sorting through them, and anything you don't agree on, you need a third, more experienced adjudicator. And so the manual sorting of these images is really time consuming and is very subjective. What I think might be a usable image, somebody else may think is not a usable image. And so at the top there, A and B, those are pretty good quality images. One is the ganglion cell layer map, and the other one is the OCT angiography. And then C and D have motion artifact, they're decentered. And so same with E and F, they have problems. And so we don't want to analyze these images or put them in a machine learning model. And so this is some of our iMIND team. It's basically many, many students. And there's Raj Kundu as one of the co-authors, where we developed a convolutional neural network to automate assessment of certain images and sort them based on good quality and bad quality. And we also want to ask ourselves, are these images that we're getting, are they repeatable? Are they, intra-session repeatability? We're looking at repeatability of our peripapillary images, of our macular images. And yes, our data shows that even in individuals who can't follow instructions with cognitive impairment, the images are still quite repeatable. Now, what's really exciting about our iMIND images, it's a super clean data set. So we've already excluded confounders. So patients with diabetes, we don't have them in our iMIND database because they have microvascular abnormalities. We've excluded patients with glaucoma because they have retinal nerve fiber and ganglion cell loss and thinning. We've also excluded uncontrolled hypertension. So we have a very tight data set with very strict image quality. And I think that's what makes our manuscripts of high caliber, even though our N is not that big, because it's hard to get these patients to want to participate. And so that nice QR code will take you to our website. But is retinal and choroidal imaging the answer to identify neurodegenerative diseases? And so this is how it all started. I was in a busy clinic because your clinic also is your laboratory. And these 96-year-old identical twins came in, and they actually both have Fuchs dystrophy of the cornea. They both have some geographic atrophy from dry AMD. They both had peripheral wet macular degeneration. And the woman on the left is 96. So these are identical twins, right? Same DNA, same genetics. But the one on the left, she's driving a car, using a smartphone at 96 years old, talking about current events. And the one on the right is her identical twin sister who had advanced Alzheimer's disease. So I said, wow, this is an opportunity where I'm going to have to break some Duke rules. And so I was actually, this was in 2017, and I was leaving the next day to actually come to Singapore. And I needed to get images of their eyes before I left. And there was so much red tape. I just called a friend who worked at Zeiss. He had a machine, put it in the back of my car. I picked up the cognitively intact twin, and we drove several hours to the community living center where she lived and got the images that we needed. And we ended up publishing this. And, genetics set the stage and environment sort of pulls the trigger, right? And so the cognitively intact twin, her color vessel density map from OCT angiography, so this is looking at vessel density, her right eye is on the left there. And so blue and green shows thinning and lower vessel density. And so she has aging changes, right? But the twin with Alzheimer's is on the right, and it shows all that blue, and that's lower vessel density. So this is what a normal one looks like. And so we knew that there was something going on here, and that's what started iMIND. And so we've also, just to digress slightly with this one slide, I had always assumed that fingerprints in identical twins were the same. So I always thought, well, the retinal vessels should also be the same with identical twins, but that's actually not true. And so twins' eyes are almost identical. There's only about a 3 to 5% difference. And these images here are from 44-year-old surgeons at Duke. So they've been subject to the same stress. They were healthy. And that's where we looked at this. So what we realized is that the marked difference that we saw in our 96-year-old identical twins is very intriguing. And the difference between twins is small. So they're not entirely identical. So the differences are smaller than what we actually saw in the 96-year-old twins. And so then we got really busy and started enrolling patients. And so this is one of our very first papers. We had 70 eyes with Alzheimer's disease on the top left. This is the representative image of the retinal vessel density color map. So we had 70 eyes and then 254 control eyes, and we saw a difference in vessel density between the two groups. We also saw a difference between Alzheimer's and mild cognitive impairment on the bottom there. But what we didn't find, because, right, we want to use these images to diagnose Alzheimer's early before symptoms start. So I was really disappointed that we didn't find a difference between controls, healthy subjects, and mild cognitive impairment. That's really where I wanted to see the difference. And it could be that we didn't have enough MCI patients. And mild cognitive impairment's a really mixed bag. There's amnestic mild cognitive impairment and there's non-amnestic. And it's also very difficult to diagnose. So we've been much more careful since then in getting a neurologist to double and triple check the diagnoses as best they can. We also saw decreased ganglion cell layer between mild cognitive impairment and Alzheimer's and normals and Alzheimer's, but not MCI and normals. So just as I mentioned, why didn't we see a difference in mild cognitive impairment and controls? Well, our N could have been too small. And as I mentioned, MCI is a really mixed bag. So we tried to look at amnestic and non-amnestic mild cognitive impairment. And we did see, because those with amnestic MCI are more likely to get Alzheimer's. So that is the group we really want to focus on. And there's a difference between these two groups. So it's very possible that our initial MCI cohort had more non-amnestic MCI patients in it, which it did. So these studies so far have been cross-sectional, right? They're just a moment in time. So we have no idea, does microvascular loss come first and then Alzheimer's shows up, or does Alzheimer's come first and then you get the microvascular loss? And so we really need to do longitudinal studies to better understand that. And so this is just a single case that I think highlights something very interesting. So I wanted to show it to you. This is a 62-year-old woman. She didn't have any of the microvascular risk factors. She didn't smoke. She actually had some vague chest pain, but her cardiac cath was clean. She has normal cognition, no hypertension, no diabetes, no hyperlipidemia. She exercises, but she has a high genetic risk for Alzheimer's. So she had both ApoE4 alleles. So she has an increased risk. And these are her perfusion density maps on OCTA from 2001 to 2004. So the top is the right eye and the bottom is the left eye. And you can kind of see, especially if you're looking for it, you can kind of imagine there's more blue than there was. Let's see, what did I press? Yeah. Um, but let's keep looking. Here's the vessel density maps. And so she has also a strong family history of Alzheimer's as well, and a sister with bipolar disorder. And so you can see the right eye and the left eye, maybe. But we think that something in this particular patient more than just aging is happening. And when we actually look at the numbers, we see that slowly these parameters over 30 months or so are decreasing over time. So we asked ourselves, well, is this the first sign of Alzheimer's in the eye? You know, she has a high genetic risk. She also had positive CSF biomarkers for Alzheimer's. She's probably headed that way. And so the vessel density and perfusion density decreases that we saw may just be slightly accelerated than normal aging. And when we look at some of our other papers, and that's what all of that says on the bottom, she actually has a 91% risk of developing AD at 68 years old with normal cognition and both ApoE4 alleles. She has her CSF and her ratio of amyloid beta is also 0.044. And when it's less than 0.059, that's indicative of Alzheimer's pathology. And so we do strongly think that the microvascular loss comes first. And I know it's just a single case, but it's very exciting to delve into it that way. So an image is worth 1,000 pixels. And that's oculomics, right? Big data, eye images, using AI to identify biomarkers in the retina of systemic disease. And this is our iMIND team. And right here, if you can see the small print, and I didn't add this, it's been here, Tan Tock Seng Hospital in Singapore, right there in our schematic. So traditional stats is helpful, but maybe we're not looking in the right place. Maybe our regions of interest are not right. Maybe the metrics and the parameters and the machine imaging machines are not right. And so maybe that's where we need machine learning, where they may be seeing something that we just can't see. So what about convolutional neural networks, right? I really like these circles because it helps those that are unfamiliar with AI kind of understand where that sits in the whole big world of AI. And so we have done some work. I have a nice group of undergrads who are very, very smart, helping do a lot of this work for us. And it's a very multidisciplinary team as well. And so we published actually the first paper in the BJO in 2020, looking at a CNN or convolutional neural network that could differentiate symptomatic Alzheimer's disease using retinal images. And so here is the schematic and shows some of the image inputs that we had. Now, because we had a low N, there were a lot of other things we used to kind of prevent overfitting and help prevent the model from just memorizing our data. And we added quantitative data to help augment things early on in our work and some clinical data as well. And so that's some of the info that we used. And our quantitative metrics from the images that were also fed into the model. And so this was really fascinating. That's from the 2020 BJO paper. And we were looking at the predictive capabilities in the CNN of the various model inputs. And we found, and we've seen this over and over again, is the ganglion cell maps, the ganglion cell interplexiform layer maps really seem to be driving things if you look at the AUC on the right. And just for those of you that aren't familiar, I put this here of what these AUC numbers mean right here. So if it's 0.5, it's no ability to differentiate. 0.7 to 0.8, it's acceptable. 0.8 to 0.9, it's excellent. And greater than 0.9, it's outstanding. And so if we look at, you can see the AUCs. We have all images gave an AUC of 0.829. All images and the data to help it made a little bit of a difference, 0.836. And then the GC, IPL, quantitative data, and patient data was the best at 0.841. So this is just an example of images from a patient with Alzheimer's disease that is then put into that model. And then the machine learning's model's probability of Alzheimer's was 96%. And these are images from a participant with normal cognition. And the purple one is the attention map. We were trying to figure out what the model was paying attention to. And we're still trying to interpret it and better understand it, because I think it's picking up some areas that are just a little faded on the image over there on A. But it's still pretty accurate, because this was a patient with normal cognition, and the machine learning model's probability of not having Alzheimer's was 99% in this particular case. So we've since also looked at a CNN using multimodal retinal images to differentiate MCI from normal cognition. And there's a table from the paper down there on the left. And again, it shows that the ganglion cell maps offered the most useful decision support over the microvascular OCTA image scans. Quantitative data provided significant decision support, and the quantitative imaging metrics provided even better decision support than the demographics. Thank you. So we're on the yellow brick road. Oh, thank you. And there's a picture of our team, some of our collaborators. I also had the opportunity to go speak when they were focusing on Alzheimer's. We had the Alzheimer's Association in the audience there at the United States Senate Special Committee on Aging. So I was a little wound up for that presentation, but it was great. This is one of my students that I brought with me who got to sit there and really experience that. Thank you. We have a lot of challenges, a lot of work to be done. This is why we need to collaborate with others. It's not possible for one person to get all of this done. Even in our careers are what, 30, 40 years? There's so much to do. And that's why Steve Jobs is a great role model, because he worked around the clock because he knew he had so much to get done in the short amount of time we have. So we have longitudinal studies underway, and we have since published one or two. We need more diverse study populations. Many of our patients are white. We need to compare to other types of dementia, like frontotemporal dementia, dementia of Lewy bodies. We still need to understand how diabetes affects these findings, how glaucoma, because all the older patients over 60, 65, which isn't so old anymore, a lot of them have other eye diseases. And so we really need to understand how those affect all these imaging parameters. We have a really nice group of patients where we know their genetic status. We have about 130 patients who have one or two ApoE4 alleles. And then we have another 130 or so that do not have an ApoE4 allele at all. And we need a lot more work on our machine learning models as well. So this genetic cohort that I just mentioned on the top left there, they're all asymptomatic. They know whether they have a ApoE4 or not. And we have 2 years of follow-up on them. So that paper there in Ophthalmology Retina in 2022 is the cohort that I mentioned. And so we see lower perfusion density in the 6 millimeter circle and ring in those that have ApoE for one or both alleles. But there were no differences in the rate of change between the group with ApoE4 and the group without ApoE4. All that tells us is in the 2 years we happened to look at it, we didn't see a change. And it also tells you that there's time for intervention. Just because you have one or two ApoE4 alleles and a higher risk of Alzheimer's, there was no difference to those that didn't have the ApoE4. So there's still time to intervene. So this work gives us so much more information. And I can't wait until we have large language models that have digested the literature out there, because none of us has the time or to just understand all the literature. But if we sat down and read all the papers on macular degeneration, for example, we could figure it out. Because you hear about people who have some rare disease and they read all the literature and then they solve their own problem. So that's where large language models are going to help us. We've also looked at our Parkinson's disease cohort. We have a lot of Parkinson's patients. And we've published some longitudinal work last year that showed Parkinson's disease has more rapid loss of the microvasculature and more thinning again of the ganglion cell layer over 2 years, about 5 times faster than normals. We have some really exciting community work going on trying to improve the diversity of our patient cohorts. We really need to do that. So we have some funding from Genentech, and we actually are going out into the community, into underrepresented areas, people who are underrepresented in clinical research, and we're teaching them about what clinical research is. They think they're going to be a guinea pig. We're trying to explain why it's so important that they participate. And so we do a survey before our educational presentation and then a survey after, ultimately to try to improve clinical trial participation. We are looking at Huntington's disease, Lewy body dementia, frontotemporal dementia, multiple sclerosis, ALS. And here are just some papers of ours trying to see what the similarities are, what the differences are. And you can see Dr. Agarwal on as a co-author and some of his team members as well. Funding is always a challenge. A lot of our work has been unfunded, actually. So all of this work is student run, which is, it's part of their curriculum and their education. We have some small philanthropy and donations that keep us going, and just passion. But we need enrollment. A lot of these patients with Alzheimer's, they have caregivers that need to bring them, right? They're not getting a new treatment. It's really no direct benefit of them to participate. So it's quite challenging. There are image artifacts when they can't follow instructions. And, around the world, we need very consistent terminology. We need consistent reporting metrics. So the Diabetic Retinopathy Clinical Research Network has standardized terminology for diabetic retinopathy research, and we really need something in this area of oculomics as well. And also, there's a lot of proprietary image platforms. We really need to standardize them using DICOM images like our radiology colleagues do. We have a very difficult time. I know with CBI and COIN, it's machine agnostic, which is fabulous. But some of these other metrics that we're looking at are not. And also, there's a lot of work being done to try to not have these images be considered protected health information. I think that's slowed down the machine learning work in ophthalmology quite a bit. And this is a lot of information on this slide, but I just want to point out something. And so I'm going to read it to you and then just try to focus on it for a second. So when are images considered PHI? So think about this. So a retinal images is unique to a person. So it's a biometric identifier. If you had enough money and time, you could trace back the image to the person it came from. So if the retinal image was created, received, or maintained by a HIPAA-covered entity providing healthcare like a hospital, it's PHI. Now jump to the bottom. If a non-HIPAA entity has the same exact image, like Google or Apple, and they're not covered by HIPAA because they're not a healthcare provider, which I don't like the word provider, but they're not a healthcare provider, plan, or someone operating on their behalf. While the image is identifiable, they're not covered or subjected to HIPAA. And so the image is not PHI. How do you like that? Very annoying. Right. So it doesn't make sense. But to try to get around this, right, there's federated learning, where you have sort of a central server and, everyone then has their own local area where they can just put their images locally and don't have to share the images with anyone. That is federated learning, and that might be a path forward. Also GANs, where you can modify different parts of the image so you can't actually trace it back to a person. So there is work being done to figure out a path forward. And this is our team, pretty big and very hardworking. And here is Dilraj Grewal. This is our local team right here. One of my colleagues and one of the fellows that I've trained along with my other colleagues. So and that's it. Thank you.
Thank
Any
you.
questions
No,
at all?
thank you so much. I think this was fabulous and really good. So just for the people listening in the audience here, and I think this is how a focused approach can lead you to. I think this has been an amazing journey. I just wanted to know, when did you started this journey and how long it took you to come all the way up to here?